In this episode of the ASC Podcast with John Goehle, we discuss the latest news in the industry, recent survey experiences, including a reminder about expiration dates, review 2025's profitability breakthroughs, and in our focus segment, we discuss malignant hyperthermia with Dr. Andrew Herlich.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, RFX Solutions, your all-in-one healthcare regulatory compliance software, MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes, compliance, eliminate paper logs and prevent drug diversion, and Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 269 of the ASC Podcast with John Goehle, recorded on February 6, 2026 from our studios in Spencerport, New York. I'm Sue Cronkite, your co-host and operations manager at Ambulatory Healthcare Strategies. As a reminder, the regulatory landscape for ASCs is constantly changing. The content in this episode reflects the most current information available at the time of recording. We encourage all ASCs to remain vigilant and keep up with any updates or new guidelines released by the relevant regulatory authorities. Joining me today is John Goehle, owner of Ambulatory Healthcare Strategies and one of the leading experts in the ambulatory surgery field. With over 3 decades of experience, John has authored more than 10 books on the ASC industry, and he is a highly regarded speaker on topics related to regulation, accreditation, and financial management.
So we live in upstate New York, and it is still very, very cold here, sub-zero temperatures at some points, but we actually celebrate when the temperature gets into the double digits here. It's that bad.
Haven't seen a lot of that recently.
No, not at all. But Sue, I'm going to be leaving you for a while. I'm heading down to Texas on Sunday to be at the OR Business Management Summit in Austin, Texas. And that's going to be from February 9th through the 11th. And the pre-conference workshop is on finance and ASCs, and I'll be doing that. And this is somewhat new. I don't usually do workshops, a workshop format, where we give some lecture and then we do an exercise and then go back and we learn from each other. Yeah. It's just, a lot of places do that. It's just not something that I've tended to do. Yeah. And now I've been engaged to do 2 in the next 3 to 4 months. So I'm very excited about it, though. I got to admit, Sue, I speak a lot and we joke about how much I enjoy it, but I'm a little hesitant, this time because it's so new to me, but at the same time excited about it. So hopefully the attendees there will have mercy on me and
I'm sure it'll be fine. And I do think once you start, you'll be excited by it all.
And I love the interaction.
A little differently.
Yeah.
Yep.
And we are hoping to bring that to some of our virtual conferences. A lot more difficult, of course, in virtual conferences. Yeah. But we're working on some ways, and we have some technology. But all of those things, it takes a while to get all of these things working, and we're still at work on that. And Sue, yesterday we recorded a wonderful session on artificial intelligence with our friend Matt Galati. And that's going to be probably in a couple weeks, right? I know you edited it, but we still have to wrap an episode around it. So
it was really interesting. He has a great way of explaining the basics of it all. And, I think we'll probably record more sessions and get a little deeper into it. But it was very good.
Yeah. And I think, so many people just assume that when we talk about artificial intelligence, we're only talking about ChatGPT or something like that, or Gemini. And of course, that was what he was trying to help us to understand, is that AI is so much bigger than just that. But what was fun is he gives everybody a homework assignment to do after the episode. So be prepared for homework. This is the first time we're giving our audience homework, I think. And so we've had some wonderful drop-in sessions recently. I mean, I think we always do, but we've been having a lot more fun with them, and they are on Saturday mornings right now. I think we'll alternate it a little bit, but we've had to make it Saturdays. A lot of discussion on surveys, and interesting, in the last two sessions, we've had almost as many surveyors as we have had attendees. These are not very large groups, by the way. So, if you feel that, this is a benefit of the Patron Program, to be able to log on a weekly basis and just ask questions or just sit back and listen to what's going on.
The surveyors tend to kind of talk about things they've seen on recent surveys, never mentioning, obviously, the place they were surveying.
Right.
But you kind of find out what people are seeing, what are, some issues that they're pointing out right now. So it's really, you learn a lot.
And I think what's really interesting about this is to hear surveyors talking to each other about their experiences. And it's just the way we are. We're always comparing notes, but now you have an opportunity as part of the Patron Program to listen in on that conversation. So again, if you want more information about the Patron Program, visit ASC-Central.com. That's ASC-Central.com. So Sue, as we're recording this, the nurses' strike is still on. Can you give us an update on what's going on?
Yeah. So the nurses' strike in New York City is going into the end of its fourth week. In a joint statement, the hospitals, there's 3 hospitals, I believe, that the nurses are from, said they had offered a fair, reasonable, and responsible economic proposal that provides annual wage increases and continues generous health care and pension benefits under an economic structure that works for all parties. And that part was quoted from their statement. However, the New York State Nurses Association said it was not enough to end the strike. So they feel they've made progress, but not quite enough. They have said that tentative agreements were reached on some of those issues. And on Thursday afternoon, which was the 25th day of the strike, 13 nurses were arrested for blocking the entrance of the Greater New York Hospital Association building. And they were all, given summons and were released. But I think they're probably trying to make sure that, they're not forgotten about, because it's just been going on so long. And geez, they've got to be freezing out there too.
Yeah. I was in New York this week, and it is very, very cold there. And this weekend in particular is going to be pretty bad. We bring this up, even though this is an ASC podcast, we bring this up because it does have an impact on ambulatory surgery centers. I was in New York talking to one of our clients down there about the impact to see what their perception, and this is a surgery center that's actually affiliated with one of the hospitals where the nurses are striking. And she actually pointed out that this was a great opportunity for them, because the nurses that are on strike, some of the nurses that are on strike, are looking for hours. They're looking for per diem hours. So there's 2 parts of this. First of all, they're getting the advantage of having more nurses than they've ever had willing to do per diem work. And the second part of it, which I think is probably even more important, is they have an opportunity to see what it's like in an ambulatory surgery center, and hopefully find it a much nicer environment to work in, and probably and hopefully demonstrating that many of the problems that they're experiencing in the hospitals that they're striking, that's part of the reason that they're striking, just doesn't appear in the ambulatory surgery industry. Yeah,
because as you said, some of the things that they've reached an agreement on might have to do with their pay and their benefits, but there's other issues. And some of those things you might be able to be a good opportunity to kind of see, let them see what the benefits are of working for a smaller place.
And the other thing I think we mentioned in last episode was that while we talk about the one in New York City, because that's the one that's getting a lot of attention, there are strikes in other parts of the country, and certainly there are nurses that are considering striking. And it's not just nurses, of course, it's other healthcare providers. So we'll keep an eye on it. I do think it's something that we should continue to track, and it'll be interesting to see how the settlement goes.
And from Beckers ASC Review, they had an article on the most profitable breakthroughs in 2025. So coding alignment and physician education were the real game changers at Precision Care Surgery Center. And according to our friend Eliza August, their administrator, they did a QI study to compare surgeon coding with their external coding vendors' facility coding over a full quarter, and that study revealed major gaps between the surgeon and the facility coding. Those results triggered a full-blown audit, and they found some concerning vendor quality issues and the need for more physician education, as well as the importance of beefing up their weak internal audit processes. The fix included switching vendors, tightening reconciliation processes, educating their physicians, and investing in smarter technology to catch those errors earlier. And so the big lesson from this is never to get too comfortable. Processes, vendors, and assumptions can quietly drift into risk without ongoing evaluation. Transparency, education, and continuous improvement strengthen compliance and long-term sustainability. Eliza noticed that they are building a culture where coding is a shared responsibility tied directly to quality, compliance, and sustainability. And I like how they talk about staying up on it, because there's so many things that you think, I fixed it, we're good, that's not a problem area. But if you don't go back and look, whether it's competencies for nurses or anything like this coding thing, if you don't stay up on it, recheck it every so often, it can really begin to kind of fall apart. So it was a good lesson.
Yeah, and so this is one of my pet peeves, and I know our another one of our friends, Christina Benton, mentions it all the time when she's talking. You need to be very careful about allowing the doctor's codes to slip into your ASC coding. Yeah. They are very different types of coding, and it goes two ways. But quite frankly, often you're missing opportunities for enhancing your revenue cycle there. But more importantly, you can get into an awful lot of trouble too if you're coding incorrectly. So this is why you have professional coders, and I think that's one of the big lessons that comes out of that particular situation.
Mm-hmm. And anytime you're sharing responsibility with different parts of your organization, you're more likely to have that double check and find out if there are issues creeping in.
Right.
So at Prisma Health, the focus was on the careful continued rollout of robotic-assisted technology for both lower and upper extremity joint replacements, advancing precision but not rushing into implementation.
I have very mixed feelings about, I think, robotics in surgery centers because I can see how it can enhance the quality, but I don't know that it is always the best option. And I think I just need to learn more about it also. Plus, it's a very, very expensive technology. And what I find is that when I talk to older doctors who have, done surgeries without robotics for a long time, they often mention that the problem is that the doctors graduating from programs are being exposed to these robots throughout the process and become reliant on them. Whereas the older doctors say, hey, wait a minute, I did this for years and it had the same quality outcomes that you had, but I didn't have to pay for such expensive equipment. So it was interesting that Prisma was talking about how they're not rushing into that implementation, and that's what I think we encourage our listeners is not to just adopt the most current technology out there until you know that it's really going to work and that it's going to be cost effective.
And 90210 Surgery Medical Center embraced AI to cut costs and boost efficiency. Thermal cameras now track OR time and block utilization automatically, improving staffing and scheduling. AI-driven scheduling and insurance verifications reduce denials, and we're eliminating time-consuming manual data entry and allowing staff to focus on higher-value tasks, which is kind of what Matt was saying is You're not getting rid of people. You need that human element, but let them focus on more valuable tasks and let some of that automated stuff be taken care of.
Absolutely, and we've seen some of this in action, too, in some of our clients. And I think it's a very exciting opportunity, and Sue, you're right. It helps us to make sure that we're utilizing that staff that we have. And one thing we talked about with Matt, too, is that our problem right now is it's hard to find staff. So it's not so much that we're going to be reducing the amount of staff we have. We're probably just going to be right-sizing the staff that we have, recognizing that the people that we're trying to hire, we might not actually need now by adopting AI.
So I guess the overall takeaway from all this is smarter use of technology, data, education, and cross-training is helping ASCs run leaner, more accurate, and more resilient operations. So, as I said, smarter use of technology. Use it for what it's really good for and, implement it in a smart way.
So I did want to talk about something that happened in New York in the last month. I actually listened to the Public Health Council, one of the committees of the Public Health Council's discussion about cardiology. And we know that cardiology is being adopted quite widely throughout the United States in ambulatory surgery centers. And of course, some of the procedures have been approved for Medicare reimbursement in those in ASCs. What was interesting in New York is New York has decided not to allow all ambulatory surgery centers to start doing these cardiology procedures. They've opted for a demonstration project where they will, through the CON process, allow some surgery centers that are majority owned by hospitals to start doing some of these procedures, and then based upon the results of this, determine what the next steps will be. It's kind of interesting because, of course, some major states, Pennsylvania, Texas, quite a number of other states right now have been very successful in implementing cardiology programs. And I think it is a little bit frustrating on our side to see another major state like New York choosing not to move forward in this area. And I'm worried about the access issue, especially in New York. We live in New York, as I think our listeners know by now. And we always seem to have very busy operating rooms, very busy emergency rooms in hospitals. The occupancy is often very high. And not to move forward with something that is known to be very safe is a very frustrating situation in New York. So I think that was a step backwards there. So we'll keep you all informed about this. I know that some of you or many of you are listeners from New York, and we'll try to keep you up to date on any changes in that. I do know that the New York State Association is quite disappointed at these developments and is working hard to try to move things forward a lot faster in the state than perhaps the state would like to do. And I think a lot of this comes down to the hospitals wanting to maintain their market share in this area. And I think that those are very profitable cases, and they just really don't want to give them up. Let's talk a little bit about some of recent survey experiences. One thing that keeps popping up, and it's always amazing to me, Sue, the number of very simple things that people end up getting cited for, and that comes down to expiration dates. And you have to be checking these dates on a monthly basis, and we're not talking just drugs. We're talking about supplies, and surprisingly enough, batteries. Now, many batteries today, if not most of them, are coming with an expiration date, and we as surveyors are checking the expiration date on your batteries. And keep in mind where all of these batteries are hiding right now. They've got they're in your equipment, backup equipment. They're in the laryngoscopes, which I mean, I've actually pulled laryngoscopes apart, and there's been batteries that have started to disintegrate in there. So that's a really bad situation. Yeah. But you need to be testing those on a regular basis and checking the batteries for expiration, and checking the batteries that you're maintaining in supply, as backups also there. So please don't make it easy for me to cite you when it comes to these expiration dates. Assign somebody or multiple people in your organization to check expiration dates throughout. And then another interesting thing that popped up was the Boston Bowel Prep Scale. I don't know too much about this other than to state, and we'll provide a reference to this, that this is a new scale that's being used by some ambulatory surgery centers, endoscopy centers, to determine how well the bowel prep worked. And the purpose here is to provide more information with regard to what is more successful, as well as how well people follow instructions. So there's like two parts of this: is how well does the bowel prep actually work, and second, how compliant are patients when they use these bowel preps. And this particular scale is particularly helpful in that. So keep an eye on that if you're an endoscopy center. Sue, you a couple months ago, I think, met Dr. Herlich.
Yes.
And can you talk a little bit about your first meeting with him, and then what transpired after that?
You were talking actually to a pharmacy consultant who mentioned him, and I had reached out to see if he would be interested in talking on the podcast. And he had called me, and he was just so interesting to talk to. He's got so much knowledge. He's been in the industry for quite
Longer
a while.
than me,
I don't want to talk about age, but
Yeah.
he's been in the industry for quite a while, and he just had so many interesting little tidbits. So we chatted for an hour or so.
I think your introductory conversation was longer than the interview.
Yeah. But yeah, I was just fascinated by him. So we were able to schedule, a call with him, and we've got the interview.
Right next, so we're going to talk about malignant hyperthermia. The first interview was about malignant hyperthermia,
Yeah.
which is
sorry, I didn't even say what it was that we talked
Right.
about. Yes.
Well, I think what's interesting is that the pharmacy consultant that recommended it was Doug Beck from Washington State, good friend and somebody that I speak with quite a bit. He recommended we have this conversation with Dr. Herlich.
And Dr. Herlich, he was a pediatric anesthesiologist, and he works with MHouse.
Right.
So,
as a consultant.
Yes.
And he's the other person at the
volunteers shop. I guess I think they're all volunteers there.
Right.
Yeah.
He's one of the people at the other end of the line if you have a malignant hyperthermia event and call MHouse. And that's what he's going to go into is what to do when this happens. And what we found as we were looking into this after Doug had made this recommendation to us is that we really haven't talked about malignant hyperthermia, certainly in any depth. And so we use this opportunity as part of this interview to remind people when you have to be prepared for it, what you need to do, and then, how to prepare for these situations.
Yeah.
So let's take a short break, and when we come back, we'll have this interview with Dr. Herlich about malignant hyperthermia.
Every ASC professional knows that running a surgery center takes knowledge, skill, and a strong support network. That's why we created ASC-Central.com, a place where ASC leaders and staff can learn, connect, and grow together. ASC-Central is a comprehensive hub for education and professional development in the ambulatory surgery industry. Our leadership bootcamps, on-demand conferences, and membership programs are designed to meet the needs of administrators, nursing leaders, medical directors, business office managers, and anyone committed to excellence in outpatient surgery. Our leadership bootcamps are guided, mentored programs that help develop the next generation of ASC leaders. Whether you're new to your role or looking to refine your skills, these bootcamps provide the structure and insight you need. And many of them offer AEU credits for CASC certified administrators and IPCH credits for CAIP certified professionals, supporting your ongoing professional certification. ASC Central's on-demand educational library gives you access to in-depth programs on compliance, quality improvement, infection control, credentialing, finance, and more. These full-length virtual conferences are designed to be both informative and engaging, not just check-the-box webinars. Many also include CASC and CAIP continuing education credits. For those who want ongoing learning and connection, ASC Central offers flexible membership programs. The Patron membership gives you access to Zoom discussions, key conferences, and a robust resource library. The Premium Access membership adds full access to all boot camps, private consultations, staff training, exclusive content, and ongoing support from top experts in the ASC field. If you want to be part of a community dedicated to raising the bar in ambulatory surgery, visit asc-central.com or email us at info@ascpodcast.com. ASC Central, bringing ASC professionals together to learn, grow, and thrive.
So I'm here with quite a crowd of people today to interview Dr. Herlich. Dr. Herlich is going to introduce himself in a second, but we haven't talked about malignant hyperthermia in quite a while on the podcast, and I thought it would be a good idea to kind of get an update on what's going on. So joining me today is Sue Cronkite, a co-host, Lori Rodricks, who is a surveyor with HHC and the Director of Clinical Services for Ambulatory Healthcare Strategies, and joining me also is Dr. Herlich. Dr. Herlich, introduce yourself and your involvement with MHouse.
My name's Andy Herlich. I'm a consultant, what we call a hotline consultant for the Malignant Hyperthermia Association of the United States. I've been in this position for more than 20 years, but my interest goes back to 1976 when I was a first-year resident at the University of Pennsylvania. And my first tutor in anesthesia was Dr. Henry Rosenberg, who went on to become president of the Malignant Hyperthermia Association. In a sense, he hooked me. And I've been interested in that since. I've been an academic anesthesiologist. That is, I practiced in a university setting for 99% of my career. There was a brief moment not, but I've been involved in so many different aspects of it. I have both a dental and medical degree, and I did it during the Vietnam War era when no vacations. I finished dental school and medical school in 5.5 years.
Wow.
No vacations. I just decided if I'm going to go to Vietnam, I'm going to go fully prepared. I did that a number of years later as a civilian volunteer, taking care of kids with burns, which kind of is a segue to malignant hyperthermia, because malignant hyperthermia can happen anywhere in the world.
Yeah.
Why don't we start, because we never quite know who is listening, so there are probably people that don't understand the importance of malignant hyperthermia and when it should be something you worry about in a surgery center. So why don't you introduce malignant hyperthermia and how it can affect an ambulatory surgery center?
Malignant hyperthermia in a encapsulated form is what's called a pharmacogenetic disease. That is, certain drugs, in this case anesthetics, and the standard 3 volatile anesthetics that are still in use in North America, that is isoflurane, sevoflurane, and desflurane, as well as the muscle relaxant used to facilitate placing of endotracheal tube, succinylcholine. Although these are rare events, they, when they do take place, they are horrifying. As I said to one of my young colleagues who was trying to prepare for one of these events, make sure you have a Pez dispenser with Imodium ready, because it's going to affect you as well. It is a costly preparation. So from a regulatory perspective, everyone refers back to MHouse, and we suggest that you have at least enough dantrolene, whether it's the Ryanodex, which is the concentrated preparation, or the standard dantrolene, enough to go through one cycle for a patient who weighs at least 100 kilos. So that would be, a case is 36 bottles, so it would be close to 20 vials for that morbidly obese patient. We're no longer treating just healthy people in that environment.
So how do we prepare for a malignant hyperthermia emergency?
All right. Preparation includes drilling, taking it seriously. Part of the problem of drills is that people don't suspend disbelief. We're going through the motions. By suspending disbelief, you're no longer going through the motions. This is the real deal. It's what's really happening without a bad outcome, because you're using a mannequin or a avatar of the patient having it. What starts it, the first sign of it may be a change in carbon dioxide. In other words, if you're looking at your capnogram, you will see an increased exhaled CO2. You will also see likely tachycardia or increased heart rate. And the last of the three is actually an increased temperature. That's if you were to graph this thing. However, all of these can happen in any order. They can happen slowly. They can happen rapidly. The slower the onset, unfortunately, the worse the outcomes. One would think just the opposite.
Yeah.
But it's actually that. Dantrolene has changed the way the outcomes occur. When I first started in training in the mid-1970s, dantrolene wasn't around for malignant hyperthermia. It was only available in pill form for patients with spasticity. The fatality rate of malignant hyperthermia in the 1970s was approximately 90%. Once dantrolene became available and was universally used, the fatality rate dropped to almost 10%. That should be a wake up and smell the roses statement for those who are trying to say, how can we save money on this particular item? It's an insurance policy. Granted, there are only, best guess, 2,500 cases across all venues in North America. That includes the office, the ASC, the labor and delivery suite, an emergency room, ICU, cardiac cath lab, GI suite, and of course, the operating room. But it also can happen on the floor a day or two later, so that a patient who's had a general anesthetic with triggering agents has an uneventful anesthetic in the ASC, and a day or two later triggers because there was enough anesthetic within the patient's body. Just took a while to trigger.
So, doctor, you mentioned a minimum of 20 vials.
Yes.
In our practice in the ASC, and I believe also was in the hospital, but I can't remember that far back. We have the requirement of the 36 vials. Is that so that you can do, if you have to do more than the first round, or so you have a backup, God forbid you had a second
Yes.
before you refill?
And the case is also from an administrator standpoint, it's an easy thing. I bought one case. The line item is a simple line item. When you start breaking them down vial for vial, it's just an administrative pain in the neck that you don't need. Because how often do you order a case or 0.25 cases? You either order a case or two cases, and it really does. I understand the cost at 36 vials. It's not cheap. I get it. But I've had, personally in my career, I've had 4 cases.
Wow.
And all 4 of them were different from each other. One was a woman who triggered on her 5th anesthetic. What today, when I had it, it was an inpatient anesthetic. But today it would have been an outpatient anesthetic. And she was lucky because she had one of the more virulent forms, because she re-triggered after we settled it in the operating room. We kept her in the PACU overnight, and she triggered again 12 hours later.
Wow.
So this stuff is, you said, yeah, it's rare. And if you're going to say, have a pair of dice, you're probably going to not ever see it. But for those who have seen it, it's really kind of frightening.
Yeah. I've actually experienced 2, one in the hospital setting and one in my ASC, and it is frightening. The second one, I felt like I was, in a fog, because it was like reliving the first one. But you went on sheer instinct, and you knew what to do. And it takes a team. It takes as you said, drilling between my anesthesiologist, 2 of them, plus a CRNA, and my team of nurses that assisted at the bedside. It was amazing how everybody just pitched in, and it really was like a symphony in the ASC setting.
Part of the drill, which is not, I don't think it emphasized enough, is to call 911 at the same time.
Yeah.
Right.
Because unfortunately, there's paralysis by analysis, and that time may be valuable in the transfer. Now, how do you transfer a patient? It just so happens that there is an article that came out, about 13, 14 years ago called The Creation of a Guide for Transfer of the Care of the Malignant Hyperthermia Patient from Ambulatory Surgery Centers to Receiving Hospital Facilities.
Mm.
It's in the journal Anesthesia and Analgesia. And quite frankly, I repeat that to so many of the calls, my consults, because there are ASCs or office-based anesthetics. The same thing applies, and that is IVs, start the procedure and call 911, because if you're in a big city, let's say you have an ASA in a big city, sure, there are ambulances all over the place, but your ASC is on a street that's one way, going in the wrong direction, and it happens during rush hour.
Right.
So that it may take longer. So all the things that you're doing, including drawing blood, even though you may not have an iStat or point of care testing device, drawing these bloods makes it easy for the hospital that is going to ultimately treat the patient to run these tests and say, okay, this was point A, and now I can track it, as opposed to you're drawing blood in the middle of the crisis at the hospital, and you really don't have a sense of where the patient started. Because this patient may have had one of those rare syndromes where they will run around with a CPK of 5,000 in their entire life. That's the way they are. And saying, oh, okay, so they have this rare event called hypercemia, which is, these are rare events. But if you're in a pocket, such as near where I live in Pittsburgh, there are families that have these things. And unfortunately, these families show up at the wrong time.
Dr. Herlich, that's a very good place to expand on a little bit. How do we avoid the situation in the first place? In other words, how do we try to avoid taking in a patient into an ambulatory surgery setting that is at high risk for malignant hyperthermia?
Well, part of the screening process, and I'm sure all ASCs has somebody in that chain of communication a priori, that is prior to scheduling. Have you ever had an adverse anesthetic? Now, the problem with this is, even if they have the genes that have this, they are called autosomal dominant. And that is, that's passed along because it's going to express itself, but it doesn't express itself completely. It's called variable penetrance. So you could get all of your ducks in a row, have the genes, the bad set of genes, and it may not express itself until the fourth or fifth or ninth anesthetic. I actually reviewed a case that we ultimately published. It came out of Pittsburgh. The child didn't trigger until their ninth anesthetic. So you can put up incredible barriers to this and say, nobody in your ASC, nobody will be treated in the ASC who's had a history of it. Mm-hmm. Although we at MHouse have made it very clear, as long as you don't use the wrong agents, there's no reason not to treat the patient in an ASC or an office-based setting, unless you have that rarest of rare, and all the families know it, where they have spontaneous malignant hyperthermia. They could trigger because the sky is blue. It's a gray day. There was 6 inches of snow on the ground. Doesn't matter. They can trigger spontaneously. But if you look at every one of these patients who has this spontaneous trigger, that you can see they don't have normal walking and upright positions. They're very easy to pick out.
So you spoke about the Ryanodex and the dantrolene. Do you see or feel that one is works better than the other? I know the Ryanodex is probably easier because it's, almost like you said, concentrated. What would you recommend when the time came to replenish your stash?
Okay. First, I have to make a declaration. I have received no money for the manufacturer of
Okay.
Ryanodex. All MH volunteers, we are free of finances. We're all volunteers. I would advocate for Ryanodex for one reason: space. This is a real estate issue.
Yeah.
Think about how much space a case of dantrolene plus the sterile water take in a space limited environment. You can stick 3 vials of Ryanodex, which is a full case of dantrolene, on your crash cart, your ACLS cart, or your PALS cart. Then you're finished.
Yeah.
Done. Because what the management of malignant hyperthermia is dantrolene, cooling, IV fluids, all the materials you would need are sitting right in your ASC to manage it. Now, to assess labs as you go, some are willing to buy an iStat to help their providers, both in the pre-op area, in the post-op area, as well as point-of-care testing during a case if there's some unusual events. But that's a strategy that's best left to the discussion of the liability people. But I would advocate that every facility have it. There is no mandate for it, but there is a mandate. If you don't have it, what are you going to do about it? Because, the hospital's across the street. How quickly can you get that dantrolene and bring it back to that ASC, even though they're one entity? So they're the owners of the hospital owns their ASC. They don't have enough OR. So we're going to put X cases. But if you don't have the dantrolene available on a timely basis, and the definition of a timely basis, and this is where we put a stake in the ground. M-House puts very few stakes in the ground, but this is a stake in the ground. And that stake is that the moment you diagnose, or you're fairly sure it's malignant hyperthermia, the initiation of dantrolene treatment should occur within 10 minutes. And I defy you to have anybody who can run that quickly across the street, grab the dantrolene, come back and do it in under 10 minutes.
And just mixing it alone is torture.
No longer. No longer.
If you're using Ryanodex, yeah.
Even the classic dantrolene is 9 seconds per vial.
Right.
It used to be a minute 9 seconds per vial.
Okay.
So I did the testing for the company when they changed over the classic, and it really cut out 1 minute. The amount of people needed went down dramatically, and rescue was more effective. I'm passionate about it because there are deaths. As a pediatric anesthesiologist, it's hard for me to say, well, we made a corporate decision here not to stock dantrolene because we needed to spend the money on a total knee prosthesis. Yeah. And how do you tell a family, well, that was sorry? That gets down the ethical rabbit hole that I am unprepared to run.
Yeah. I do want to point out, as a surveyor, we as surveyors expect to see 36 vials of dantrolene if you're using dantrolene and 3 vials of Ryanodex if you're using Ryanodex. And again, that's the expectation of the surveyor.
Well, and the correct amount of diluent, because sometimes they may not have enough sterile water and they don't even realize it, and it's like you've just defeated yourself.
Yeah, the real estate argument is very strong, especially when it comes to the diluent. That would
Yes.
take up quite a bit of space. I just did a survey last week where they were using Ryanadex, and I noted that the malignant hyperthermia cart was mostly empty. To your point, because they didn't need all the stuff that the typical or dantrolene-laden malignant hyperthermia cart would require.
Yeah, the nice thing about the MH cart was it had a refrigerator in it. Great. But there are refrigerators all over the world. And even if you don't have refrigerated IV fluids, think about the delta or the change. A patient is going through this crisis. They now have a temperature of 105. If you administer room air IV fluids, that's 30 degrees cooler. And that really, in a sense, really what you need are ice bag or something, give ice or ice packs to the groin and as many body surfaces. We no longer recommend the use of rectal tubes and chilled fluids through the Foley. The problem is for us that we think scientifically, we really want to know how effective the circulation is and what the kidneys are pouring out. And if you're trying to lavage the bladder or kill the bladder, now you've lost that monitoring. The other thing is putting in a rectal tube. That's basically a lost art. And if you push a lot of something cold through a rectal tube and it's misplaced, you may add trauma. That's why we don't recommend that you force down an NG tube, because you can create a source of bleeding. If you're going to put down a tube, put it down orally, but certainly not nasally if you are worried that you're going to create trauma.
So speaking of those types of updates, there's the new 2025 poster that M-House has come out with. And what are the key changes that you see?
Honestly, there are so many of them. They're nuanced that I can't remember all of them. I think the key ones, I think the most important thing is that we haven't changed our stance on within 10 minutes of diagnosis, start it.
Okay.
Even if you have some concerns of where in the ASC has occurred, put your dantrolene or Ryanadex in a little tackle box and run like hell with that. That's another easy one to do. But it's all about dantrolene, and make sure that this patient continues to be monitored for a minimum of 24 hours after the event. And that's why early transfer is so important.
Yeah, you bring up a very good point here, is that we usually tell our clients, our centers, when a code occurs, to wait until the doctor has determined that the transfer, should be made imminently. In this situation, don't even hesitate. Have it part of the protocol to immediately call 911.
Right, because you need to get all the advantages of a hospital up front, and literally this event will paralyze the function of your ASC.
Yeah,
immediately, because the amount of help needed takes away from the ability to run another set of operating rooms, or 3 operating or 4 operating rooms, or even a GI suite that's attached to your ASC. All that comes to a grinding halt. And I think that transfer is also best for the patient. You need help.
We should also point out that as soon as you have a malignant hyperthermia event, and heaven knows it's infrequent, but it actually reduces your ability to do other procedures until you replenish your dantrolene or Ryanadex supplies.
Yes.
It doesn't mean you have to shut down, but it does mean you have to stop doing procedures that could trigger malignant hyperthermia.
Yes. I mean, if you're using non-triggering agents,
right?
That is, you take all of the vaporizers off your anesthesia machines. and have no succinylcholine.
Right.
You could do anything. You don't need it.
Right.
But realistically, I don't know of a facility that doesn't have a vaporizer on it.
Yeah.
Just because it's specifically sevoflurane, because sevo seems to be the most utilitarian. And for those of us old enough to remember halothane, sevo is the go-to for pediatrics and for mass induction of anesthesia. I think we will see desflurane less and less because A, it's costly, and B, its impact on the environment. It's a bad thing in the environment. Nitrous oxide's the worst, but that's a different discussion.
Right. So when there is an event and your staff has called 911 and you're then calling the hospital, is it imperative that you let them know that it's an MH crisis because most ERs may not have dantrolene in there?
Yes.
Okay.
And
that's a very good point, Lori, is that you're calling both the emergency services to get the transfer, but also find out where that patient is going. And that can be a problem in some locales, like even where we live in Rochester, New York, or where many of our clients are in New York City. You might not know until the ambulance gets there exactly where that patient is going to be going.
Yeah, I mean, they're going to a hospital. The hospital has mandates, but they need the same resources
right
available on receiving. We also think it's probably not a bad idea to send the dantrolene or Ranadex with the patient.
Got it.
Just in case. Whether a physician should go, the anesthesia provider or the nurse that should go with that ambulance is a bit of a political challenge.
Yeah.
Because as you can imagine, some people get bent out of shape if there's somebody else calling the shots in that ambulance, and that becomes a legal thing. I think if you're in Pittsburgh, okay, doc, tell us what you need to do. Come along. We could use your help because we don't know about this.
Best thing you can do is volunteer.
Right. You can volunteer.
Yeah.
I can tell you if this happened in Philadelphia, where I trained from, and you even had the hint in your brain of joining them, you would be an unwelcome party for the rest of your career.
Yeah.
So it really is highly variable how it works and who it works with.
My anesthesiologist went in the ambulance with the patient to the hospital. Fortunately, the patient was transferred to a hospital that they also had privileges at, but the ambulance group were more than happy to have him there in the event that he needed to continue giving the dantrolene that they had no training on. Yeah.
That requires, I think, part of the drill. And you may want to add that from a consulting perspective, is invite your local EMS folks to be part of that drill. If they're available, they suddenly become a team member, understand what's going on, and will be probably more receptive to having help. Because how many people are in that ambulance? The patient, the driver, and one person in the back.
Yeah.
And when an MH crisis is occurring, you need at least 2 or 3 people to get this to work.
Right.
And that may make it easier for that transfer to be a team effort, and rather than perceived as we don't want it here, just please get this patient out of here.
One of the things that I realized when having this crisis happen at my ASC was also thinking about the family members that are sitting outside. Because they don't know what's going on. And depending on the size of your center, if you're one room, then they know it's their family that all hell is breaking loose. If it's multiple rooms, now you have quite a few panicked people, wondering, because, as much as you try to hide things or come in a back door, if you're in a city or whatnot, they're coming up the elevator. they're, that sort of thing. It's, that should be considered something to include in your drills, I believe. And oftentimes, possibly the surgeon with a leader in your organization will speak to the family, because that surgeon is scared to death and is not prepared for what's going on. That's not in their repertoire.
Yeah.
No.
They're not helpful at that moment.
Yeah.
And they need a script.
Yeah.
And I would highly recommend a loosely framed script
Oh, that's a great idea.
for this.
Yeah.
What we're doing, why we're doing it, and why it's important to transfer the patient, and being very loose about what the prognosis and what's going on, because we say, okay, what's the likelihood of this being a bad outcome? Or say let's say it's 1 in a million. But if that patient's that one, that's 100%. And if that patient isn't that one, they don't care about the statistics. They only care, are they that one or not?
Yeah.
And just say, we're doing absolutely the best that can be done anywhere in the United States. And you and emphasize that. I've been involved in enough cases as a phone call person along the way. I no longer do phone calls. I just do these email requests and discussions, but recommending that you help the families and the providers, and recommending from your organization that you have somebody within the organization who is a professional debriefer and grief person or emotional person. Because if there's a bad outcome, the toll on the providers is pretty frightening.
Yeah.
The first one I had, we actually published, I believe, in the Ladies' Home Journal of Good Housekeeping, because of the second victim effect. Because I know of two docs and 2 nurses who quit healthcare as a result of this unexpected outcome. It had been a healthy 21-year-old whose family genetics were unknown, without going into details. And he unfortunately was the perfect storm and died despite every effort. And this kid required 40 milligrams per kilogram of dantrolene.
Wow.
Per day. And still we lost him.
Right.
So, but the grief for us is too often hidden from the public, but it's real.
You're right. You don't even always think about that. You have to take care of yourselves as well.
Yeah.
As the patient and the family. Yeah. That's a very strong point.
Yeah. It's the families, won't appreciate it till maybe years later that their caregivers do care. We care and we're giving it, and we have that toll because medical school did not prepare me for a bad outcome.
Oh, sure.
Dental school did, because what's the worst possible thing that can happen? You took out the wrong tooth. Nobody died from taking out the wrong tooth.
Yeah.
But there are other things, and we were not prepared for it.
Right.
I'm lucky that time has allowed me to heal from some of the bad outcomes that I've had.
Right.
But we need more of that.
Let me ask you this. I was recently at a ASC, and we were talking about MH. We were looking at their stuff. I was looking at their poster, making sure they had it. And what the director of nursing told me is that they actually do their drills with M-House.
Yep.
On the phone.
Yep.
How does that work? That sounds phenomenal.
What we take, it takes a month or two in advance to try to plan it, to get people. There are only about 30 of us in the United States who do these things.
Okay.
And trying to get one of us who's available at the hour that they want to do it. Once we set it up, they call us over the phone, and then they say, this is their avatar patient, blah, blah, blah. And well, did you do this? Did you do that? Please do this. Please do that. And we make sure there's no bad outcome for emotionally, but we want to see how they go through the drills. This is at a cost. There is a fee for this.
Okay.
Now, I'm not sure who gets the money. I've never seen it, but they have offered. Most of us decline the money and put it back into the organization because we're operating on a shoestring. There are two women who run this actually in the upper tier of New York, and that's it. There's just two of them to run it, and that's where the monies go. And of course, sending out the posters and all the other little things that people need for MH. But one thing I really think is important is that once you think there's an event, calling 1-800-MH-HYPER gets you to an active anesthesiologist who will walk you through the event. The phone call actually goes to the Rocky Mountain Poison Control and then Medical Alert Foundation, one of those two. Mm-hmm. And then they get a hold of us. I'm the only one who does not do that anymore. Mm-hmm. I aged out, so to speak. But I do every one of these things. If you submit a question through the internet, I answer every one of them for the last 8 years, I guess.
Mm-hmm. Oh, thank you.
Except when I'm on vacation. No, it keeps me from getting my wife all annoyed because I'm doing something else. No, seriously, this keeps my brain in gear.
Mm-hmm. Well, and you had said you said everybody's volunteered and more are going to be aging out. So hopefully we'll get more people who, kind of find this a passion and maybe want to join in.
For the age that there are more aging out than coming in.
Yeah.
And that's going to be a real challenge because the average age right now is over 65. That gets a little unpleasant.
Yeah, and I do want to go back and reemphasize. There's two phone calls you're making. Number one to 911, and the second one is to call M-House right away so to help through. It's great to have the poster, but you're going to need more than the poster.
Mm-hmm.
Yes, and it's really important that somebody also, if you have that ability, to take as many notes as you can, because after this is over, there's another phone call to what's called the North American MH Registry, which is at the University of Florida. And they gather they de-identify for other purposes, but if family members want to know is there a registry in my family? I think there may have been one. Can you go search it? That's also very helpful for future, because sometimes someone who's labeled as MH is not, and they recommending genetic counseling because the old days of muscle biopsies are largely gone. There's only one center left in the United States for civilians, and that's at the University of Minnesota. All the others have closed because of finances, and the military has one at Bethesda. And the University of Toronto is the only center in Canada. So basically, we're going on genetics now.
Okay.
And genetics are reasonably effective. They're not 100% like a muscle biopsy is, but they're better than nothing.
And is there a certain population that we should be more cautious with?
Yes. Those from Quebec, from the province of Quebec, a bunch of families in Wisconsin. Matter of fact, the index case in the United States was in Wisconsin. There is the members of the Lumbee Indian tribe or Native American myopathy along the Carolina coasts and as well as southwestern Pennsylvania, a few miles away, about 50 miles away from where I am. And in two of the issues, consanguinity is a real issue, i.e., family members having interrelations.
Yeah.
And that really, unfortunately, makes it that much harder to deal with these and dilute, because the key to the end of MH is diluting the gene pool.
Yeah.
This is one case where you don't want to preserve it. You want to dilute it.
Mm-hmm. Mm-hmm.
And that research is actually going on now of, can we use genetics to actually, there are only 3 genes that we know of so far, 3 different genes. And can we go after them early in the patient's life to use snipping, get rid of that gene, and then substituting a benign gene.
Gotcha.
Okay.
But that's realistically, our grandchildren may be the benefit,
Yeah.
Mm-hmm.
or great-grandchildren may be the benefit of that generation. Although so many things are happening at warp speed now with genetics, that
It's hard to
I may be around to actually see it.
Gosh, I hope I'm not.
Well, I mean, talking about it's that much faster.
Yeah.
Right. Oh no, I hear you. I remember being involved in doing muscle biopsies on patients or family members. Oh yeah.
When I first started in this business, there were 30 biopsy centers. And that's how quickly. So I'm in my mid 70s, and there were 1976, there were 30 or 40 biopsy centers. And here we are, we're down to 1.
Yeah.
And we're not even sure that's going to survive.
Right.
In Europe, they have lots of biopsy centers, but they largely depend upon genetics anyway.
Mm-hmm.
Small countries like Germany, relatively speaking, have 4 biopsy centers. There are 2 in Switzerland. There are a number of them in Great Britain.
As we finish up here, I just wanted to thank you for, coming on. I know it's been reduced to 10% mortality rate, but that's still too much. So
that's still a pretty high rate of death, which we need to take into consideration. And the chance of it happening is very small, but once it does happen, 10% mortality is something we would all be very concerned about. So
I'm not sure, how do you tell it up front?
I don't think I'd want to tell the family member, certainly, but it's something that your staff needs to know and be cognizant of and realize going into it that it's still an important thing to draw forward.
Right.
Dr. Herlich, I really appreciate this. We are definitely going to have you on again. You have many other areas of expertise, which I'm sure would be great with the audience, and I really appreciate your time today.
Oh, this is a real honor. It's 5 degrees in Pittsburgh right now. And let me tell you, I can't think of a better place to sit here in my office where it's warm and have such a nice reception. And it makes this 45-year career.
Yeah.
It helps to put some cherries on the top of this cake. So Thank you for putting a big cherry on top of my cake.
Thank you.
Thank you. Well, again, we appreciate your time, and we hope to have you back soon.
Thank you so very much, John. Thank you, all of you. It's just been a real honor. Thank you.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff, and other events in the ASC industry.
So as we mentioned in our first segment, the OR Business Management Summit is in Austin, Texas from February 9th through the 11th, about the time that this episode will go out. And the registration is open right until the day of the show. I mentioned this because I'm going to be doing a pre-conference session on financial. It's going to be a workshop on financial management in ambulatory surgery settings. So I'm very excited to do that, and definitely try to make that conference in Austin if you want to escape the cold weather from the northern states.
And the American Academy of Ambulatory Care Nursing's annual conference is April 14th through the 17th at the Hilton Orlando in Lake Buena Vista, Florida.
And ASCA and SAMBA are getting together for the annual conference and expo, which is May 13th through the 16th, 2026, in Washington, D.C. And Ambulatory Healthcare Strategies and the podcasts are going to have a booth, and I'll be doing a session on strategic planning there.
And the Gulf States ASC Conference, which is Alabama, Louisiana, and Mississippi, is June 17th through the 19th at the Ritz-Carlton in New Orleans.
And the Florida Society of Ambulatory Surgery Centers annual conference and trade show is July 22nd through the 24th at the Hyatt Regency Grand Cypress in Orlando, Florida.
And CASA's annual conference and exhibits is September 2nd through the 4th in Monterey, California.
And the Pennsylvania Ambulatory Surgery Association's annual meeting and educational conference is October 4th and 5th at the Eden Resort in Lancaster, Pennsylvania.
The Atlantic States ASC Conference, which includes North Carolina, South Carolina, and Virginia, is October 8th and 9th at the Embassy Suites, Raleigh-Durham Research Triangle in Cary, North Carolina.
The New York State Ambulatory Surgery Center Association's annual conference was November 17th through the 18th at the Desmond in Albany, New York. And don't forget, on-demand versions of the ASC Director of Nursing, the ASC Administrators, and the ASC Business Office Managers bootcamps are available on our sister website at ASC-Central.com. And as we mentioned in our first segment, please think about becoming a patron member of the podcast. There's all kinds of benefits for becoming a patron member. More information at ASC-Central.com. The biggest advantage, I think, the one that a lot of people take advantage of is the weekly drop-in sessions where we give you a link to drop in through Zoom. You can either ask questions or just sit back and listen to our conversation there. And we have really grown, I think, a lot because of that. Another big benefit of the Patron program is the access to a number of free conferences that we do periodically, such as the Conditions for Coverage Conference, the Finance 101 Conference, and Credentialing and Privileging. By becoming a member, you have access to a database of information, including policies and procedures in various forms. So as I said, more information about it is available at ASC-Central.com, and your support helps us to maintain and grow the podcast, covering essential costs like research, travel, equipment, and production. And as I said, to learn more, visit ASC-Central.com.
Thank you for tuning in to this episode of the ASC Podcast with John Goehle. We hope you found the discussion insightful. If you did, please share it with your colleagues in the ASC community and be sure to subscribe so you never miss an episode. We appreciate your feedback and any suggestions for future topics. Please reach out anytime at comments@ascpodcast.com.
And a special thank you goes out to our incredible team, sound editor Susan Cronkite, executive producer John Goehle, and our committed research team, which grows every day. Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Zach Calritis, Jim Masters, Stuart Rosenberg, Amy Cronkite, Lori Rodericks, Kathy Foti, Donna Macchio, Christina Norman, and Katie Pearson. Their hard work makes this podcast possible.
Our theme music is by Media Sushi and Mike Noah. The ASC Podcast with John Goehle is hosted on Podbean and can be found on all major podcast platforms. Thanks for listening, and we'll see you in the next episode. This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, RFX Solutions, MedServ, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. RFX Solutions is your all-in-one healthcare regulatory compliance software. MedServ, which offers the only digital narcotics cabinet specifically designed and priced for surgery centers, helping develop standardized processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.